Somushila from LVPI, Mamta Agarwal from Shankanetralaya, and Kalpana Babamurthy from Pabaya Clinic. We will start with confocal microscopy. I do not have any financial disclosures. In vivo confocal microscopy is a non-invasive technique that can demonstrate anatomical details of organs at the tissue level. It has been used successfully to visualize the corneal lesions and other pathological findings that are generally not detected by other clinical or diagnostic methods. A condenser to focus the light source within a small area of the cornea and an objective, which has the same focal point, hence it is called confocal as the condenser. The morphological patterns of KPs we know we have fine, medium, large or mutton fat keratic precipitates or pigmented keratic precipitates. In confocal, we can differentiate based on the morphological pattern either infactive or non-infactive patterns. Sometimes we can have overlap between both the patterns in many diseases. What we have is a globular or multiple globular, which is seen in VKH in sympathetic ophthalmia, stippled pattern in case of non-granulomatous uveitis, the conditions like rheumatoid arthritis and HLA-B27 associated uveitis. In infective patterns, we have central globular with dendritic in case of tuberculosis and toxoplasmosis. Dendritic pattern is seen in viral infections and also an infiltrative pattern. This infiltrative pattern commonly seen in zoster and herpes simplex virus infection. CMV anterior uveitis has been reported by Professor Chi et al. Tsudashi has demonstrated the classical owl eye pattern in CMV anterior uveitis in immunocompetent individuals. We'll move on to the case examples. Stipple keratic precipitates is seen in ankylosing spondylitis. Globular pattern in a case of sympathetic ophthalmia. Here is a case of a Fuchs heterochromic iridocyclitis, where the anterior chamber tap confirmed its chikungunya infections and classically showed tripod dendritic pattern in a case of chikungunya infection. In addition to that, we also seen central globular with dendritic and infiltrative pattern in chikungunya anterior uveitis. Here is a 78-year-old male diagnosed of acute anterior uveitis following application of topical photophylline. Adverse reaction score was 7 as obtained. Patient was treated symptomatically with topical steroids, and application of topical photophylline was stopped. Confocal microscopy shows subepithelial deposits, activated keratocytes. Following stoppage of the drug, with topical steroid applications, we could see resolution of this pattern. Here is a case of ocular tuberculosis, which is ACTAP for the PCR came positive for MPB64. Confocal microscopy showed central globular with dendritic pattern. This patient was treated with systemic ATT, systemic and topical steroids, following which the confocal pattern changed from central globular dendritic to pigment clumps. Here again is a case of ocular tuberculosis, where we had a classical mutton fat keratic precipitates, central globular with dendritic. Following treatment with topical steroids and anti-TB drugs, we could see the resolution of the keratic precipitate. Syphilitic panuveitis showed infiltrative pattern of keratic precipitates. Following treatment with antisyphilitic therapy, there was a complete resolution of this pattern. Here is a case of frosted branch giangitis with retinitis secondary to toxoplasmosis. Confocal microscopy showed classical central globular with dendritic pattern. Following treatment with antitoxin systemic steroids, there was disappearance of the keratic precipitate. Here is a case of a herpes zoster showed an infiltrative pattern. Following antiviral therapy, the pattern disappeared and formed pigment clumps. Here is a case of sarcoidosis showed a mutton fat keratic precipitates. Confocal microscopy showed a globular pattern. Following treatment with systemic steroids and immunosuppressive therapy, we could see the resolution of the keratic precipitate. Keratic precipitates are far more heterogeneous and variable on IVCM compared to slit lamp microscopy. Even though both TB and sarcoid had mutton fat keratic precipitates, they have different morphology on confocal microscopy. IVCM can be used as an adjunct investigational diagnostic tool in uveitis. However, further studies are required more clearly to define the KPs in each condition. Thank you for your attention. We'll take up the questions later, ma'am, because of the lack of time, and also we start a little bit late.
Okay.
Yes. We'll invite the next speaker, Dr. Somashila Murthy from LVPI, to speak on anterior segment OCT in uveitis.
In the meantime, there is a request by the organizer
for inviting me for this very interesting imaging symposium. And Padma, you have a very good extra positive point. We're all women in ophthalmology doing this. So thank you. I'm going to quickly take you through anterior segment imaging and what is its importance. Is it even useful for inflammation? Just to remind ourselves that there are dedicated machines available which can do this. The OptoView, or we were part of the research of it, we used to call it RTView, is a derived system converted from retinal lasers, and that is a very good imaging modality, especially for the cornea and also the anterior segment. Whereas the Zeiss Visante, it's a dedicated anterior segment OCT, and it gives much more comprehensive information, which includes the angles and the iris structures. So if you have the OptoView, then you get very good imaging sections of the cornea, including epithelium, Decime's membrane, as well as the anterior segment just beyond the cornea, as well as the Visante will give you even more detailed images. So it's good if you're in a setting where you have both. So the applications in uveitis and ocular inflammation, it's useful for edematous corneas. You can't see beyond the cornea very well, especially in those where you expect that there could be angled foreign bodies which are driving the inflammation, or you have a malposition intraocular lens which may be driving the inflammation, or an ACIOL, you can have UGH syndrome. You can have, it also is useful to monitor granulomas on the iris, and I like this technique of it, because sometimes we see the patient on clinical slit lamp examination, we take photographs, but the three-dimensionality of the anterior segment OCT, I think, wins over the other modalities as well. So it's a useful adjunct. It can also detect KPs and inflammatory cells, not that we can't see them, but it's very interesting in doing it for these reasons. What about in traumatic uveitis? We can look at, of course, things like Decime's rupture as well as corneal trauma, but we can also look for occult scleral perforation if they're closer to the limbus. In the case of traumatic uveitis with hypotony, look for a cyclodialysis cleft, foreign bodies again, and in case there is some dislocation of the lens. So I'll just quickly take you through a few interesting cases. This is a 23-year-old young man who presented with a penetrating injury some months ago and came in with really nothing on the cornea, maybe the entry wound, and then a nice ball sitting like this. This is not sitting on the cornea. So when you do the OCT imaging, you see that actually this nice looking, well, not nice, ugly looking ball is sitting in the iris, and it's a little bit incorporated into the anterior part of the iris stroma. This is the same thing again. So the patient was a farmer by occupation, so we did an AC tap, injected both antifungal antibiotic, and culture showed that it was fungal ball, which was not surprising. Our clinical diagnosis also, it looked like fungus only. But we could follow up this patient serially and make sure that there was no residual, both on clinical examination or anything on the iris structure resembling the fungus, and the patient did well and resolved. One other very beautiful illustration of serially following up patients using this tool is what Dr. Padmamalini has already published, and this is a patient who was diagnosed to have Hamilton's disease as well as leprosy nodules, which were active nodules actually, and over a period of time the patient improved with medical therapy, and she had this beautifully shown in her paper how with treatment the patient, the nodules flatten and they ultimately resolve. So this is the final outcome for this patient, showing the resolution. Whereas notice if you see the clinical picture, you don't get that impression that it's actually flat, whereas you see the OCT, it looks really convincing. The second case I had from my series was a boy who presented to us. He had injury while he was hammering a nail playing. And already the corneal tear was sutured. There was this mass-like tissue stuck onto the iris, which looked very suspicious of a foreign body. So we imaged him with radiology, and we also did anterior segment B. We also did a B scan, of course, and it didn't really reveal a foreign body, but we had our own suspicions. So we also used the AIOC. Again, it suggested that there was no foreign body. So the patient was scheduled to get this exudate removed because there was still some suspicion of a foreign body in the center. And when he removed that exudate and studied it, there was no foreign body. So this is a correlation Clinically, it was really hard to figure out whether there's a foreign body entangled in this mass of exudate. The OCT image shows that there is a reflectivity, but there is no sharp reflectivity which you would expect with a metallic foreign body. So this helped us sort of make the decision, though we did have to go ahead and remove the exudate, but we had a pretty good idea that there would be no foreign body. Utility in scleritis: in the normal eye, the sclera is very uniform. It's indistinguishable in terms of its boundary between the conjunctiva, like this image, for example. Whereas when you have scleral inflammation, there's a clear separation between the conjunctiva and the sclera. So not that you can't diagnose clinically, but in cases of scleritis, you can pick it up with the help of OCT. Not the same tool, but it has to be a slightly enhanced OCT for scleritis. So its utility is that you can detect it in cases of scleral thinning in necrotizing scleritis versus non-necrotizing. You can see whether the thinning is progressive, or you can see how is the patient benefiting with treatment, has the thinning stopped. And this is using a polarization-sensitive OCT. So it's slightly still in a research mode, not yet available. And also useful in the case of nodular scleritis to look at and monitor the nodules, whether are they improving with therapy. The last that I'm bringing out is probably, in my mind, not as very interesting, but maybe clinically not as relevant. It's measurement of AC inflammation. So there's several papers already published which talk about grading the anterior chamber cells. You literally have to sit and count those cells using the images. And what is the usefulness of this? So if you have an edematous cornea, you can still figure out how much inflammation is there in the anterior chamber by having a method in which you pick up the cells and you count them, and you can grade the inflammation and use therapy, monitor that to see if the patient is getting better or not. So I'll not go through the papers, but there are very interesting ones. So similarly, I had this 43-year-old lady with recurrent anterior uveitis, and she came in recently with increased flare-up. Again, she had antechamber cells and fibrin, and the lab workup we had done earlier had already revealed a elevated serum ACE, so it's sort of a presumed ocular sarcoidosis. So this clinical picture shows the chaetic precipitates pretty large, fibrin at the pupillary membrane, and early synechia. And this is not that you can't see anything, but this is again just to capture. So this is a large chaetic precipitate which is captured with OCT, sitting on the Descemet's membrane when you take the cut through the inferior cornea. This is the amount of cellular reaction which we correlated as 2 to 3 plus that we could see clinically in the patient. So if you have a series of patients, you can go on correlating with what is 1 plus, 2 plus, 3 plus, and capture it on the ASOCT with the cellular reaction. It's really pretty interesting. And also the fibrin that was sitting on the lens, very beautiful. And also in the inferior part, you can see there's this early posterior synechia. So you can see that is bridging the two sides of the iris. So that is just a very nice clinical and OCT correlation. So it's underexplored perhaps, indications, we'll definitely have more indications for this. And we need to have clinical correlation, as I mentioned, so we need to establish our standards first. And for me, currently, the role is excellent in cloudy corneas or poor visualization and in the detection of occult foreign bodies. Thank you very much.
Thank you, Dr. Somashila, for the illustrative talk on anterior segment OCT. Next, I invite Professor Wek Chi Soon from Singapore to speak on ultrasound biomicroscopy in uveitis.
Good afternoon. I'd like to thank Padmamalini for inviting me to participate in this course. And I searched the literature on papers on UBM, and surprisingly, there were very few. And they were mainly concerning its imaging of the pars plana region in pars planitis. So I'll share with you my clinical cases, which I think are quite interesting, and how I use it in my clinic to help me in the diagnosis. So UBM is used to visualize ocular structures anterior to the pars plana. It functions on principles similar to the B scan, which is actually using 10 megahertz, but this UBM uses a 50 megahertz probe, and this results in better resolution. Although it's a less penetration to about 5 mm, there's also a smaller angular field. It's able to image not just the cornea, iris, and sclera like the OCT, but in addition, the cerebral body and zonules. So these are normal structures here. So let's have a look at the first case here. This 58-year-old gentleman actually presented with blurred vision and was found to have isolated cystoid macular edema, investigated and was found to be quantiferon positive and referred to infectious disease for treatment, and he got better. 6 months later, he presented again with worsening vision in the right eye, and there was now cells 1+ in the anterior chamber. You can see the cornea is actually swollen with descemet folds, and the endothelial cell count was unreadable. His pressure was normal. At this time, we did an anterior chamber tap, which was negative for viruses, but nonetheless, we still treated him with Valg and cyclovir without improvement. At this time, the cornea specialist saw him and diagnosed a pseudophakic bullous keratopathy. And on follow-up, we found that his lens was tilted. My fellow saw this, and so we decided to do UBM. And you can see, indeed, this was a subluxated IOL. And this patient, I had to bring him to surgery to basically fixate this lens because it was actually dipping into the vitreous cavity and had been swinging forward and backwards and causing both the cystoid macular edema as well as inflammation in the anterior chamber. And you can see at the end, I glued this lens so that it was really securely in place, and it was really very stable. So let's have a look at this second case of a 9-year-old boy who presented with blurring of vision for 2 months. As we know that children are not very good historians, but he said he had some floaters. He was otherwise well. His vision was light perception, and he was really prethysical. There was a total retinal detachment, and my colleague asked me, well, is he going to benefit from surgery? We didn't even understand why he had a Bannon keratopathy. In fact, he had a slight Bannon keratopathy in the fellow eye, and there's absolutely no view of the back of the eye. So we did a UBM, and you can see actually that the ciliary body is really quite featureless, and he had atrophy at 360 degrees of ciliocoroidal detachment, and we felt that this suggested poor prognosis for retinal detachment surgery, and we left him. This third case is a 52-year-old interesting Chinese gentleman presenting with redness and pain in the left eye with previous history of cataract surgery and subsequently retinal detachment surgery 2 years prior. He had anterior chamber cells, and you can also see some medium chorotic precipitates here and some retrolental cells. The back of the eye was normal. There were no retinal lesions. However, a tap from the vitreous actually grew coagulase negative staph, and he was treated with appropriate antibiotics. However, he did not seem to get better. He had increasing hypopion here, and you can see that his iris had a peculiar kind of folded pattern, and it was rather thickened, and peripheral anterior synechia formed. You can see the modified KPs here that were quite impressive. So we did a UBM, and this was many years ago, but you can actually see that the images here are still clearly showing irregularly thickened iris and ciliary body with low to medium internal reflectivity. And his condition did not improve. We did a second tap, and this time was negative for bacteria, and so we started him on steroids. But 2 weeks later, he was taken ill, and he was admitted for investigations. And we also did an iris biopsy when he was in hospital, and we actually were able to see lymphoid infiltration, but no significant evidence of mitosis there. We sent the tissue to Chi Chow Chan in NEI, and she did microdissection, but she was not able to detect gene rearrangement. However, other investigations showed that he was positive for syphilis, he was HIV positive, his CD4 counts were low, he was subsequently found to have a sigmoid colon mass, and biopsy actually showed high-grade diffuse B-cell malignant non-Hodgkin's lymphoma. And chemotherapy resulted in the iris lesions that resolved. So we concluded that this was actually a B-cell lymphoma infiltrating the iris and ciliary body. This last fourth case is an 83-year-old gentleman who was having his usual medical illnesses like diabetes, hypertension, stroke. He was a smoker, past history of cataract surgery. He presented with pain for 2 months in the right eye. He was otherwise seemingly well, and this was the eye at presentation, hardly injected, but he had cells 2+, chorotic precipitates, vitreous cells 1+, and you can see here a vitreous tap actually showed candida. And the cytology showed predominance of lymphocytes. He was quantiferon positive on investigation, and we referred him to the ID, and they felt that candida was a contaminant, but TB was offered TB treatment. He was getting worse after 2 months when he defaulted, and he came back. You can see his vision dropped, but he also appeared to have something happening in the angle here. And a UBM actually showed that he had a large mass here, irregular mass, that was quite extensive. And this patient, we subsequently brought him to surgery because we were uncertain whether this was TB, fungus, or malignancy. And this subsequently showed a moderately differentiated SCC. And when the source was looked for, we actually found that the patient had cancer of the lung and also The scans also showed that he had probably previous TB to explain his positive quantiferon results. So in the end, this patient refused any further treatment and requested enucleation. So the learning points, UBM is useful for examining the iris, cerebral body, anterior chamber angle, pars plana region, and the zonules. I have not given you an exhaustive list of possible applications. In other cases, we've also found it's able to detect cilioretinal detachment, anterior rotation of the cerebral body, like in a patient with acute VKH who presents with angle closure glaucoma. It's able to demonstrate the cerebral body status, especially when we are considering surgery and the eye is rather hypotenuse. Thank you.
Thank you very much, Professor Chi, for the excellent illustrative talk, the role of UB. Thank you very much. Next, I invite Dr. Kalpana Babamurthy from Pabbai Clinic, Bangalore, to speak on role of ultrasound B scan in uveitis.
Me in this instruction course. So to start off, ultrasound has been with us for a very long time now, and it is a non-invasive diagnostic tool, and the main intention is to assess the structural integrity and pathology of the eye. So a brief on the history, it was Munt and Hugh who first used it in ophthalmology. Oxala defined the different sound velocities in the various components of the eye. Baum and Greenwood gave a two-dimensional immersion scan, which was improved by Pernell and Coleman. And the contact B scan was developed by Bronson, and this was a portable form. So what does this ultrasound contain? It contains a standardized A scan, which is a time amplitude scan, a B scan, which is the brightness mode or the two-dimensional scan, and then incorporate some of these ultrasound machines also have color Doppler ultrasounds, which can look at vascular tumors. Now, basically, this is a dynamic procedure, and you have a real-time evaluation for diagnosis. So suppose if you're seeing after movements, you can do it well on the ultrasound. So the standard procedure when you're performing an ultrasonography, what you're trying to do is screen for a lesion, and this is done by both the A and the B scans. And then you look at the topography. So you look at the shape, the border, the location, and the extension, which is done by the B scan mode. The quantitative ecography, you look at the reflectivity, any sound attenuation it produces, and the internal structure, which can be assessed with the A scan. And kinetic ecography, that is the mobility, after movements, and vascularity with the B scan and the Doppler. So the A scan uses the frequency probe of 8 megahertz, while the B scan uses about 10 megahertz. So what are the indications in ophthalmology? We look at intraocular details, which we otherwise cannot see because of the media opacities. We look at retinochoroidal lesions, the choroidal thickness, if there's any scleral inflammation. Are there any, is the mass which is there, is it a cystic or homogeneous? And is it a solid or a cystic mass, or is it a homogeneous or a heterogeneous mass? So by this, you're able to say whether it's a cyst or are you dealing with an abscess. Retrobulbar soft tissue masses, for example, in patients with proptosis. And you can look at foreign bodies and collateral damage. Is it associated with any vitreous hemorrhage, any retinal detachments? And it is used for follow-up evaluations and, of course, biometry. The red highlights are those which are the common indications which we use in uveitis. So let me start with a few examples where we use ultrasonography routinely in our practice. And this is one thing which is very common, total cataract and Fuchs heterochromic iridocyclitis. So you need to look at the posterior segment to know whether everything is all right. And this is important, especially with regard to the prognosis. This is an interesting patient who has chronic anterior uveitis. If you see, he has a complicated cataract, he has a PI done elsewhere, and he has these large peripheral anterior synechiae, and he has a perception of light, and projection was accurate. So you really need to see what is there behind the eye, whether you're just going to plan only cataract, or you're going to do a vitreous procedure along with this. So ultrasound will help us, because otherwise you're not able to see anything beyond the anterior segment. Now, this patient had generally otherwise a clear vitreous, but he had a glaucomatous cupping on the ultrasound, so it's easier for us to explain the visual prognosis, and this patient improved from perception of light to around 618 vision post-operatively. So thus, it is very useful in our practice to assess the posterior segment and vision, give a prognosis following cataract surgery. Now, this is another patient who had a query. He didn't come with a history of uveitis. He came with recurrence of uveitis, but he didn't give any history of trauma. And he had these lesions on the endothelium, which was mistaken as keratoprecipitates. But then it's not very clear, but these look very different from what you normally see as keratic precipitates. So we just did a B-scan because we couldn't see on the slit lamp biomicroscopy, or we couldn't see the fundus. And this is what you see, a dislocated lens. And when you ask him, he says he had a history of trauma in childhood. So again, such cases, again, this gives you a better picture of why he is developing inflammations. Now, when I was mentioning about the cysts or the abscess, this is one case where it's a subretinal abscess and it is progressing, and ultrasound helps us to document this better, the measurements and their response to treatment. Now, this is a patient with granulomatous panuveitis with fluid in he had these iolym flows and hyperemic disc, and we did a B-scan and it showed choroidal thickening. And this was a patient with VKH. Again, you can see this in sympathetic ophthalmia as well. However, in recent times, we are using more of EDI OCTs, especially in these cases, to follow up these patients of VKH who are on treatment. Now, this is another case where the ultrasonography is very useful. This is a patient, again, one eye presenting with exudative retinal detachment. And this is another case where you see lots of chorioretinal folds, and he gives a vague history of pain on moving the eyes. And this is what you see. This is the T sign which is present, and this is because of inflammation and fluid in the subtenon space. So this is one of the very useful indication of ultrasonography in patients with posterior scleritis. So this is a patient, again, the same patient post-treatment with steroids. This is an interesting case of a 30-year-old lady, and she did not have any significant systemic history. Her vision was 6/9. She had occasional vitreous cells. And this is the picture which she had. She had an exudative retinal detachment. Again, the fluorescent angiography did not give us much information except that the optic disc wasn't leaking. So at this point of time, we did a B-scan, and you see the choroid is irregularly thickened. And this patient, again, on further investigations, actually had a choroidal thickening because of metastasis due to a breast carcinoma. Now, this is another indication where we use ultrasonography. And this is patient with cysticercus cyst, and this is from the subretinal space coming into the vitreous. And it is very characteristic where you have a high spike which corresponds to the scolex which is there. So ultrasound is quite useful in these patients, especially when they come with a ruptured cyst and you don't know what is happening. There's a lot of inflammation in the posterior pole, and the ultrasonography shows a high spike corresponding to the scolex, and then you know what you're actually looking at. So this was a ruptured cyst with inflammation. To conclude, there are a few indications in uveitis where we routinely use ultrasonography, which I've highlighted with these cases. It is definitely a non-invasive diagnostic modality. Again, its importance has come down slightly because of increasing use of OCT. However, there is always a definite indication in uveitis, especially in patients with media opacities. Thank you very much.
Thank you very much, Dr. Kalpana. Dr. Mamta Agarwal from Shankar Nethralaya to speak the role of fundus fluorescent angiography and indocyanine angiography in the diagnosis of uveitis.
Good evening, all. So after the beautiful talks of the anterior segment by my previous speakers, I would like to take you to the posterior segment of the eye where we deal with posterior uveitis. So fundus, fluorescein angiography, and indocyanine angiography. So uveitis, as we know anterior, intermediate, posterior, or pan-uveitis, but the diagnosis in these cases depends not just on clinical findings, but a lot of laboratory tests, ancillary tests, pathology in few cases. They help us making a diagnosis. So the posterior uveitis is a different entities, as we see in these clinical pictures, can range for just choroidal nodules to multifocal choroiditis or serpiginous choroiditis. Different ancillary tests are available, and in the next few minutes we'll go through fluorescein angiography and indocyanine green angiography. How would they help us in these clinical conditions? So FFA, as we all know this, was started in 1960 by MacLean and Momini, but what is important in fluorescein sodium is that it fluoresces in the range of visible light, and it helps us see the superficial structures of the eye, like retinal vessels, disc, macula, subretinal space, choriocapillaries, and retinal pigment epithelium. The two things what we read in an FA, hyperfluorescence, which can be due to a transmission defect, as we see here, because of the overlying swollen choroid, or it can be a filling defect, hyperperfusion, which again gives us hyperfluorescence. It can be hyperfluorescence, where there is diffuse leakage, as we see in these cases from the retinal vessels. It can be increased transmission defect because of the atrophy of the retinal pigment epithelium, or it can be abnormal vessels which are leaking. They all lead to hyperfluorescence. So the different entities where we need these tests are listed here. Let's go through a few of the entities. It helps us confirm a clinical diagnosis. As we see here, this is a yellowish lesion in the posterior pole, but when we do an angiography, what we see is early hypo with a late hyper, which begins usually at the edge of the lesion and helps us delineate the clinical condition better. It's a case with serpiginous. Another case with a VKH in the acute phase, what we know is that posterior pole subretinal fluid, but when we read the angiography, there are few hypofluorescent dots, as we see in these eyes, and the late pooling in the subretinal space, the classical glassy pattern of hyperfluorescence. But not just it gets us to a clinical finding, but there are certain conditions which are not so obvious clinically, and these angiography helps us clinch the diagnosis. As we see here, it's a chronic phase, stage of VKH, where a 52-year-old patient had come with blurred vision for the last 2 months. The vision was 6/9/6. If we just look at the clinical picture, it looks quite okay with no inflammation, vessels and disc look normal. But what happens when we do an FA here? It's a cystoid macular edema, which was not probably seen here, and OCT picks up the finding even in more details and gives us a quantitative analysis. How about this case? It's an intermediate uveitis. We know obviously snowball exudates, but what happens in FA? We are seeing more findings, disc leakage, a petroloid pattern here, and again a cystic macula. So this patient, where we see that fundus looks more or less normal, the disc looks pretty okay, vessels are normal, but when we are doing an FA, again we are seeing a stellate pattern because of the breakdown on the capillary tight junctions in the fovea. What we all know leads to perifoveal leakage of the dye. How about this case? This is a case where the patient, a 34-year-old patient, comes with decreased vision in the right eye with 3 months. Clinically seeing, we're not obviously seeing clinical vasculitis, but we are seeing diffuse scattered hemorrhages and a large disc edema. But when we do an FA, there's diffuse vascular leakage all over the fundus, tells us the severity of inflammation, which helps us guide the management in these patients. And this patient was treated with steroids and antitubercular therapy because of the investigation, and this is the fundus 6 weeks later. Besides vascular leakage, we can also pick up these areas which are hypoperfusion, the choroidal non-perfusion areas. And how about these where there's neovascularization of the retina? It's a hyperfluorescence lesion. It also helps us grade the inflammation better. Like in this patient, what we see clinically, we can say there's dense vitritis, a little less in this eye. We're not seeing any other finding here. But when I do an FA, what we can see is there is macular edema here. There are vessels which are leaky, both in the periphery and the posterior pole. And how about the left eye? Left eye also shows a similar finding. So it is a bilateral disease with a lot of vascular leakage. Again tells us how the disease is affecting both eyes. And how about this patient? This was an interesting patient, and patient underwent phacoemulsification with intraocular lens. But glass appointment, not very happy. I do an OCT where it's a cystic macula. We give it triamcinolone acetonide injection. He improves on OCT, but again, patient is not really happy. At this point, when I do an FA, the inflammation is much more than I was seeing clinically. Hence, patient needed a little more stronger treatment to control the inflammation, as evident by FA. It also helps us monitor the disease intensity and modulate our therapy. Like this patient was a Behçet's disease patient, but what we see here, just scattered hemorrhages, few areas of vasculitis. But when we do an FA, we see such a large extent of non-perfusion area. What we see here, it's the neovascularization of the retina. So besides just the leakage, it helps us, we need to control inflammation, we need to do a laser photocoagulation so that there is no further complications in these patients. How about this patient? This is a patient referred from a neuroclinic where there was inflammatory optic neuropathy with vasculitis. There were just few vitreous cells. But FA, when we do look at the inflammation of the vessels, it definitely tells us much more inflammation lying in these eyes than what is clinically obvious. But not just inflamed eyes, it also helps sometimes in patients who just have healed choroiditis, areas of retinal atrophy, which may pick up subtle areas or disc leakage. As in this patient, this is a normal patient with no vascular leakage or disc leakage. It also helps to tell us that the eye is quiet and we can just monitor the patient without treatment. So besides FA, another thing what we have is indocyanine green angiography, which was studied in 1970 by Flor and Hokema. Now, in indocyanine green angiography, it fluoresces in the range of infrared wavelength. Hence, it visualizes choroid through RPE, which is not possible with an FA. And it evaluates inflammation of the choroid. So the clinical conditions, we know these serpiginous, multifocal choroiditis, VKH, Behçet's. But what's different from fluorescent angiography, what we see in the next few slides? As we see here, this is a patient with the right eye, burnt out choroiditis. In this patient, if you see, there is a subtle inflammation coming yellowish lesion here besides the inactive lesion. When we do an angiography, we're not picking much here, but what we are seeing here is hypofluorescent areas, which increase in number in the later stage, which is much more than what we are seeing in the FA. So because it studies choroid in a little more deeper aspect, it's much better in these patients to follow these. This is just a comparison with the choroidal granuloma. It's an ICG which makes up a hypolesion and an FA which makes a hyperlesion, suggesting of active lesion. This is a patient with sarcoidosis, sarcoid uveitis with multiple granulomas as we see here scattered all over the fundus. But when we do a multimodal imaging, this is an early FA and this is an early ICG where we are picking early hypofluorescent dots corresponding to the granulomas. So this is the multiple lesions, what we are seeing in the right eye. And we saw the similar finding in the left eye. As we see here, these hypofluorescent dots suggestive of active lesions. This was a patient with macular serpiginous choroiditis. As we see these yellowish lesions who are active. But when we do a multimodal imaging here, what we see, this is the activity, what we see in FA, and again a hypolesion in an ICG. Besides choroiditis, this also helps patients with choroiditis and CNVM. This looks a little complex here because it's difficult to differentiate what is active and what is not active and what is the complication. But again, in this, when we compare different scans with ICG and FA, we are able to pick up these findings in a more clearer way and help manage the patient. This is the left eye of the same patient. So in conclusion, I would say these are important diagnostic tools and they help in monitoring the disease activity. It helps us dose our corticosteroids and immunomodulator therapy and gives us a better understanding of the disease pathology. Thank you so much. I thank Padma for making me part of this course. It's been a pleasure. Thank you.
Adaptive optics and inflammation.
I'll just take it out.
Optical coherence tomography is a non-invasive, non-contact imaging modality that provides high-resolution cross-sectional images of the retina and choroid. It gives us in vivo optical biopsy of the tissue. We moved from time domain to spectral domain. We have various generations. Mostly I will be concentrating and sharing an experience using spectral domain OCT in the diagnosis of posterior uveitis. Of late, the swab source is coming with more promising because of the deeper penetrations where with the single scan we can image the larger area and good depth penetration. Optical coherence tomography uses based on the low coherence interferometry principle. We will see case examples. The regular screening protocol of normal OCT gives the good view of all retinal layers of the retina and inner part of the choroid. Recent classification by Richard Spade have changed the terminology. The outer retinal layers, what we commonly call it as ISOS junction, have been changed into myoid and ellipsoid zone and interdigitation zone. And also we can name all the layers of the retina, and we can differentiate the choroidal layers as well. Normally we use OCT to quantify the cystoid macular edema to titrate a treatment. EDI has revolutionized to understand the pathology better in cases of posterior uveitis. In EDI, where the OCT instruments is brought closer to the choroid, so the choroid is placed closer to the zero delay, we get the images, where we can differentiate the choriocapillaries, Sattler's layer, Haller's layer, and suprachoroidal lamina. We have a combined depth imaging, where we do 50% of the normal scan and 50% of the EDI merged together gives the combined depth imaging, where we can see the vitreoretinal interface and the outer border of the choroid in a better way. Here is a case of a 46-year female diagnosed to have a multifocal choroiditis due to tuberculosis, where we could see the choroiditis lesions. The autofluorescence images shows hypo surrounded by areas of hyperautofluorescence corresponding to the areas of the activity. FFA shows early hypo with late hyperfluorescence and disc leakage. Here is a combined depth scan shows altered foveal contour, where we can have hyporeflective choroidal granuloma with a contact sign, and outer retinal fluid serous detachment is also there. This patient was started on ATT and systemic steroids, following which we could see the resolving outer retinal fluid, and following the treatment with ATT and steroids, we could see the resolution of the granuloma with the restoration of the normal retinal layers. This is the last follow-up where we can see the hypoautofluorescence lesions, the hyperreflective area corresponding to the areas of the choroidal granuloma. The next we'll move on to, here there are two conditions, both have whitish or yellowish lesions in the retina. The left, on your left, shows multifocal retinitis associated with retinal hemorrhages. Here you can have a multiple cottonwool spots. How do we differentiate in addition to the clinical? Here OCT helps us to differentiate. In OCT we could see the presence of posterior vitreous cells, hyperreflective echo on the inner retinal layer corresponding to the areas of the retinitis with aftershadowing effect with hyporeflective fluid filled spaces in the outer retina. Whereas in cottonwool spots where we get focal areas of hyperreflectivity without any aftershadowing. So we can differentiate using the OCT between the two conditions. This kind of multiple cottonwool spots commonly seen in SLE and also in HIV retinopathy. Here is a case of a 28-year male who diagnosed have a multifocal retinitis in both eyes. OX2 and OX19 came positive for the tick typhus and was treated with systemic doxycycline and systemic steroids. FFA shows early hypo with late hyperfluorescence, disc leakage, and vascular leakage. The OCT shows hyperreflectivity in the inner retinal layers with aftershadowing. Following treatment, we could see the restoration of the normal retinal layer in this patient. So recently we published our experience in rickettsial retinitis from the Indian perspective in JOII. The other case is a case of an SLE who has got multiple cottonwool spots suggestive of a SLE retinopathy. Here again, the autofluorescence shows hypoautofluorescence, no activity suggestive of, and FFA shows early hypo with late hyperfluorescence with filling defect. Here you can see the focal areas of hyperreflectivity. This patient treated with systemic steroids, systemic immunosuppressive therapy with targeted laser photocoagulation of the CNP areas, following which we could see the resolution of inflammation in this patient. Here is a 10-year-old boy diagnosed with toxoplasmic retinochoroiditis, where you can see the bilateral toxoplasmic scar. And in addition to that, you could see the yellowish-white ill-defined lesions in the right eye macula. When we did the OCT, we could see the breaks in the RPE Brooks membrane complex with hyperreflectivity in the hyperretinal layer with hyporeflective areas suggestive of a fluid-filled space. Here, the child has associated CNVM in addition to toxoplasmosis. Following anti-VEGF injections, we could see the resolution of the fluid with the decreasing in the CNVM height. FFA also shows early hypo with hyperfluorescence with increasing in the staining and leakage of the CNVM complex in the late phase. Next, we'll move on to VKH. Dr. Mamta has already highlighted the use of FFA and ICG. ICG shows more extensive involvement compared to the FFA. The OCT shows altered foveal contour with hyporeflective spaces that intervening septa, which has been described by Dr. Vishali et al., along with focal areas of hyperreflectivity in the outer retina, in the inner part of the choroid. With the conventional OCT, we can't penetrate because of the edema. We are not able to go, but with the SEPS force, we can penetrate into the outer border of the choroid, which is seen in this case. Following treatment, we could see the resolution of the serous detachment. However, the increased choroidal thickness is seen in this case. It's yet another case of a VKH where, in addition to the ILM folds, we also can see the choroidal folds. Following IV methylprednisolone administration, we could see the disappearance of the folds and the restoration of the normal foveal contour with the retinochoroidal complex in this patient. Now we'll move on to the chronic case. Chronic case, most of the times they have sunset glow fundus. The visual acuity is normal. They present with recurrence of inflammations in the anterior segment. But when we do an ICG, it shows us the extent of involvement in the choroid. Here we can see multiple hyposinus and dots are seen in both eyes. So when we do OCT, combination of OCT with ICG, the focal areas of hyperreflectivity is seen, suggestive of a scar, and we could see the hyporeflective area suggestive of a granuloma, suggesting that this patient has active inflammation which is going on in the posterior segment. The next, we'll move on to the other conditions like acute retinal necrosis, where we can see the alteration of the retinal layers where almost is eaten away with degeneration. The similar structures is seen in progressive outer retinal necrosis, where we can correlate with the histopathology. Chikungunya retinitis, again, it's chikungunya, rickettsial all come under epidemic retinitis, where again you have a focal areas of hyperreflectivity after shadowing. The effect is seen. In toxoplasmosis, where we have full thickness involvement, hyperreflectivity in the retinal layers, and focal areas of hyperreflectivity corresponding to the areas of the chorioretinal scar. So this suggests the reactivated toxoplasmic retinochoroiditis. Here we have used additional plus lenses to study the hyperreflective echo surrounded by a hyperreflective circle in a case of intravitreal as well as in subretinal cysticercosis, where V-scan is the gold standard which has been demonstrated to us by Dr. Kalpana. Here we have used a OCT to document the changes. Here is a case of a 30-year female, 9 months pregnant, came with sudden decrease in vision. Clinically, she is diagnosed with acute posterior multifocal placoid pigment epitheliopathy. OCT also shows altered foveal contour with hyporeflective spaces with cystic spaces and hyperreflective echoes in the inner aspect of the choroid. We did not do anything. We just observed this patient where we could see where here again the disruption of the external limiting membrane and the myoid ellipsoid zone was noted. We just followed this patient. After 6 weeks, we could see the complete resolution of the lesions with restoration of the normal retinal layers in this case. Here is a case of a posterior uveitis due to sarcoidosis. OCT shows the presence of posterior vitreous cells with hyporeflective lesions in the choroid. The EDA shows increased choroidal thickness. Following treatment with systemic steroids, we could see the decreasing in the choroidal thickness in this case. Here is a case of a granulomatous panuveitis where we have a mutton fat keratic precipitates. The confocal use already I showed it in my earlier talk with the choroidal granulomas. OCT shows well-defined areas of hyporeflectivity within the choroid. Following treatment, we could see the decreasing in the size of the lesions. Here is a case of a posterior uveitis with ill-defined yellowish lesions. By looking at the clinically, we cannot make out it's retinitis or retinochoroiditis, but the OCT shows hyperreflective in the retinal layers is one of our earliest scan, shows well-defined hyperreflective lesions in the choroid suggestive of a choroidal granuloma. Here is a patient who gives history of fever and history of IV fluid administration was given. So ACTAP PCR for TB came negative, but panfungal genome came positive. Following antifungal treatment, we could see the decreasing the size of the granuloma, where OCTs helped us to localize the granuloma in this case. Here is a case of a multifocal choroiditis. On fundus examination, we could see the localized areas of the retinal hemorrhage. But when we do a OCT along this point, we could see the breaks in the Brooks membrane with hyperreflective echoes in the outer retinal layer with hyperreflective fluid-filled spaces suggestive of active choroidal neovascular membrane in this case. Angiography is the gold standard and ICG can pick up, but OCT also can pick up to CNVM in these cases. Here is a 13-year-old boy, repaired open globe injury in the right eye. It's a classical sympathetic ophthalmia where you can see the granulomatous inflammation in the anterior segment and multiple exudative retinal detachment in the posterior segment. FFA and ICG confirms the same. The OCT shows the presence of posterior vitreous cells, internal ILM folds, and serous retinal detachment. Following treatment of 3 days of IVMP, we could see the serous detachment is decreased, and patient was started on systemic immunosuppressive therapy as well. Follow-up, we could see the resolution of the inflammation in this case. Here is a case of an 8-week-old infant suspected to have a CMV pneumonitis. On examination, we could see 3 discrete, well-defined choroiditis lesions in the right eye and ill-defined lesions in the left eye, which is found to be active in the left eye. Handheld OCT shows focal areas of hyperreflectivity in the outer retinal layers with well-defined hyperreflective structures in the choroid suggestive of a choroidal granuloma. When we investigated, not only the child but also the mother found to have active tuberculosis. We started the child on ITT. During the course, the child developed a cold abscess in the preauricular region. Following treatment, we could see the complete resolution of the granuloma in this child. Next, we'll move on to adaptive optics. Adaptive optics is a non-invasive imaging of the retina on a microscopic level with a lateral resolution of 2 micrometer that compensates for the optical aberrations of the eye. The resultant image is of eye contrast and with good resolution. With the adaptive optics, we can see the cone mosaic pattern, and also we can do the cone cell count. We can study the lamina cribrosa, study the retinal blood vessels, and RPE. Here is a few case examples of a 29-year-old male diagnosed of idiopathic retinal vasculitis. FFA shows staining and leakage of the vessels in the right eye. Adaptive optics shows perivascular cuffing. Following treatment with systemic steroids, we could see the disappearance of the pattern in this case. The next case is a case of a 59-year-old female, granulomatosis with polyangiitis, showing sheathing of the arterioles. FFA shows staining and leakage and also the disc leakage. Adaptive optics shows parallel sheathing pattern. Following treatment with systemic steroids and immunosuppressive therapy, we could see the disappearance of the sheathing in this case. This work, which was published recently in Ocular Immunology and Inflammation. Next is a case of a 32-year-old male diagnosed to have multifocal subpigenoid choroiditis due to presumed ocular tuberculosis. Right eye is a healed one, left eye shows active lesions. FFA shows early hypo with late hyperfluorescence with staining and leakage. OCT shows disruption of the ELM with ellipsoid and myoid zone with increased choroidal thickness. This patient was treated with ATT and systemic steroids, following which the visual acuity has improved to 6.6 and N6, but the patient was unhappy with the vision. He was complaining of discomfort and glare. But when we did the adaptive optics, in the main cone cell count in the right eye was 10,000, whereas the age-matched normal one was 24,000. Not only there is a decreased count, but also there is a disorganization of the cone arrangement in this case. The same similar changes was noted in the left eye too. This could explain his unhappiness. Next, to conclude, OCT provides a non-invasive technique of imaging the uveitis. It is able to help us to localize the anatomical level of involvement. Adaptive optics can be used to study the cone cell count and retinal vessels morphology, following which, after therapy, in case of inflammatory conditions of the posterior segment of the eye, the use is evolving. It is still at the research level. Thank you for your attention.
For your kind invitation. And, yeah. I know everybody's tired. I won't take very long. So when we talk of the autofluorescence, we all understand by now, we have seen the beautiful images what Padma and Mamta have shown. Autofluorescence is nothing. The lipofuscin is in the RPE cells, so which produces autofluorescence. When the RPE cells are dead, we don't see autofluorescence and these areas appear as dark. So where can we use them in uveitis? In uveitis, one thing we have to understand is these are the changes which are imaging RPE. So whatever modalities we have seen so far, none of them is actually imaging the retinal pigment epithelium. So is it a replacement for ICGA? Probably not, but these kind of complement each other. And this is the patient where we are seeing the ICG showing beautiful granulomas, but when we do the autofluorescence, we are actually seeing the changes which are far more than the ICG. So probably the ICG will produce non-perfusion when the RPE cell dysfunction is the maximum. But before actually you get this dark spot, there are some changes which happen in the background, and if you really are interested to know, maybe you can combine the two. So why would we do the autofluorescence? Like you have the Behçet's disease, active retinitis resolved. So we all know that the Behçet's disease, normally when the retinitis resolve, it does not lead on to much damage. The cause of the vision loss are different. Those are the vascular occlusion and all. But per se, if you manage well, you don't have any RPE changes, so your patient is going to respond to therapy. Sometimes for certain diseases which are known to involve RPE, no other modality other than autofluorescence will be useful. For example, this patient comes, he's a 40-year-old man, and he says he has decreased vision in both the eyes. We looked at the eye, it was not really beautifully normal looking fundus, but there was nothing abnormal we could make out. We did the fluorescein, again we did not point out, and we did see that the vessels, there was something happening, but that was it. Other than that, at least we could not figure out. We did it in the left eye, we did see there was something happening along the blood vessel, there was this whitish area, but fluorescence did not show any vasculitis, and this was the autofluorescence. So we decided to follow him up 3 months later. Now look at the autofluorescence. These are the changes happening at the level of the RP. If you look at the fundus in a busy clinic, you would pass it off as normal, but not the autofluorescence. This is the left eye, again showing the symmetrical changes, and 5 months later the disease is progressing. So this is when we do the ERG, which shows bilateral reduced response, though the based purely upon this. So we diagnosed it as pigmented paravenous retinochoroidal atrophy. So some of these conditions, especially the dystrophies and all, where RPE gets affected, can be very well picked up on autofluorescence. Thirdly, we can study the RPE changes in choroiditis. So we can use it for PIC, for APM, PPE, serpiginous choroiditis. And what we have already shown is that serpiginous choroiditis, there are 4 stages. Stage 1, when the disease is active, there is hyperautofluorescence. As it keeps on getting better and better, you keep on getting mixed autofluorescence, but it is predominantly hyper. Then it becomes stage 3, where it is again mixed, but predominantly hypoautofluorescence. And finally, it becomes stage 4, which is totally dark. So this is how we are monitoring. For example, if I see my patient at this stage, now clinically when you see this one is totally healed, this one is kind of healed, this one is partially healed. But when you see clinically, everything appears very good. So you are tempted to stop the steroids and continue on ATT alone if you are doing that. But if on autofluorescence I see this, or I see the tip showing a little bit of autofluorescence, I'm not in a hurry to reduce my steroids, because this is where the disease is going to expand. After the autofluorescence, let's talk a bit about angio-OCT. What essentially is angio-OCT? It is a functional OCT. It's nothing, it's not an angiogram, it is an OCT. The OCT has come down to a level where you can actually measure you can visualize the RBCs, the blood cells, and it is showing you the intraluminal flow. This is how we see. We have the superficial plexus, which we are used to of seeing. In addition, we are seeing something called deep plexus, which we are yet interpreting. So in contrast to the angiography, we have two plexus. Then we have the outer retina, which is totally dark because there are no blood vessels. So anytime you see blood vessels here, think of RAP, R, C, and V. We have choriocapillaries. We can superimpose these images. And we have B-scan with which these can be correlated. Same thing can be done in black and white, which actually shows you the better result because those colors are really pseudo colors. Now, where would I use my OCT angio in uveitis? Now, this is an example of CNV. You showed those, Padma showed those beautiful, and Mamta showed those lovely angiograms with hold, healed choroiditis and all. So what happens in all this hullabaloo is you tend to miss a small little CNV. So this is a patient comes with multifocal choroiditis, diagnosed as panuveitis, so all those investigations done. So previously somebody had diagnosed there was some peripapillary blood seen and no anti-VEGF was given. So when I look at it closely, I do see some hemorrhage. But believe me, this we have started looking more thoroughly now. Earlier, sometime we would just ignore. We do a fluorescein. It shows a membrane. But do we need to do a fluorescein? This is what shows it more beautiful than fluorescein. Because when I do fluorescein, if I look at this and this phase, I'm not really seeing the lacy pattern to call it a CNV. So there is nothing which tells me whether it is a choroid, whether it is a patch of choroiditis, is it a combination? But when I do angio-OCT, this beyond doubt shows me that this is a beautiful network out here, and you see, even if I don't have the OCT based on this, I would be very happy giving an injection. Then we have the lesion which is healed. This is the patch of choroiditis which has healed. Now the patient still not having good vision, so we are wondering what it is. ICG should have helped, it doesn't. So we are looking at this anastomosis here. Is it a development of RAP? When we do OCT, it does show these vessels and it shows it could be a RAP lesion, and we do see on ICG these are 2 points which are kind of hypercyanent. But when we do OCT angio, we see this loop formation between this, and this is following anti-VEGF injection. We see the resolution and the clarity. Detection of choroiditis, for sure, it does help in choroiditis, and we have recently published comparing it with the ICG. For example, this choroiditis, ICG shows hypo to hypo, fluorescein shows hypo to hyper, and when we do angio-OCT, this does show the lesion, and the lesion has hyperreflective borders, and these are the borders along which the lesions progress. And what we noticed in patients with paradoxical worsening, that those are the ones which are having these hyperfluorescent edges are the ones which are likely to develop into paradoxical worsening, and this we have published recently in Retina. The question for uveitis people still remain, would OCT angio be used to pick up the recurrences? Now this is an example of a patient with VKH. We do see on ICG the whole lot of dark spots and the fluorescein suggesting and the OCT. Now when we do angio-OCT, we see a lot of these dark spots which actually look just like the way you would see them on ICG. We follow up the patient and these dark spots keep on disappearing. As you would see, the OCT is becoming normal. From here to here, these dark spots also keep on decreasing. But in the left eye, when we see, he has a similar picture, ICG, fluorescein. OCT angio shows these dark spots corresponding to this whole area of detachment. And when we see this detachment is going down, these dark spots are disappearing, and by this stage, very few dark spots, and this stage, still very few. The patient somehow stopped steroids on his own and has recurrence. And when you have the recurrence, you see these dark spots coming back again, and you can actually look at these dark spots and look at the recurrence pattern non-invasively. So the conclusion is that non-invasive image modalities are the way to go, so we are learning more and more about them. Thank you.
As the OCT angio, we are not able to do.
We are not able to. But I think that makes it better use for, especially in uveitis, because the moment the dye starts leaking, it kind of masks everything. So there are certain conditions like diabetes, that intercapillary ischemia, because in diabetic macular edema, the fluorescein will start leaking and you don't know what is happening to ischemia. Now we don't see the leakage, we can document the ischemia much better. Same is for new vascularization or for CNVs in choroiditis, because you don't know whether it is choroid which is leaking, whether it is CNV. So here you can see two things very clearly. So I would.
And also I'd like to get one more thing. In case of healed choroiditis, also we are seeing some kind of a pattern in the choroidal vessels.
Yes.
What is your comment on that?
There is now, we are developing an algorithm with David Saraf and Bailey Fraun, where we are trying to get leaking versus non-leaking membranes separately. So till the time we have something like that, we are not able to we are not too sure whether the vessels that we are seeing are leaky or non-leaky. So what I do in practice, if I am seeing them for the first time, I give one injection, even if there is no fluid on OCT, and I look, is there any pruning or reduction in the complex? If there is a pruning or reduction in the complex, I will give a second injection. If there is none, we believe they are mature and I will not pursue it, if it doesn't respond to first or second anti-VEGF injection. But very soon there would be a software which will be able to tell whether these are just mature vessels or they are leaking vessels.
Thank you very much. So